Morning, everybody. Welcome to the conference. It's here at last. It's exciting. I'm Sarah Gardner, and I'm a trustee for the Society of Tissue Viability, and I'll be your moderator for this session. And so thank you all for coming in early. It's great to have you here, enjoying breakfast. This is going to be a great session. So first of all, just as a little heads up, if you have a smartphone, can you just get that ready? Because we're going to be asking some questions, and that will be displayed a QR code on the screen. So those of you at the back, I think there's some screens either side, and when it comes up, you'll just need to scan that to come across the questions that we want you to ask. So rather than fumbling in your bag in a minute, if you could get that ready, that would be great. Thank you. So first of all, a huge thank you to Ergo Medical for sponsoring this breakfast symposia. Really, really appreciate their support. And I'll repeat it at the end, but they are exhibiting here. I think it's stand 42. So if you have any questions after this symposia, please do go and visit them on the stand there. So we've got two fantastic speakers this morning who are going to talk to us about evidence-based practice. We know that wound care is a significant burden on the UK NHS, with huge costs associated with that. But we also know that there's a real lack of consistency in wound care. I personally feel that maybe it's the underlying cause isn't really addressed adequately. But what we often find is there's a focus on dressings, and it would be amiss of me to say that dressings aren't important at an exhibition or a conference like this. They absolutely are. But we really need to understand where dressings have come from and the evidence behind that to ensure that your treatment pathways are sound and we get the right outcomes for our patients. So that sort of the evidence-based isn't always clear around sort of how we use dressings or how they work. And today our speakers will set out the importance of evidence-based and research behind the development of certain modalities to ensure that treatment pathways are effective. So, as I said, we have two fantastic speakers. But before I introduce the first one, I'm going to ask you a couple of questions. So if we could just have you all scanned your codes. So the first question is around whether you consider you have an evidence-based standardised approach to wound care delivery. So if you could answer that question, please. Okay, so you can see some of the answers there. I try, and people do try, don't they? But, do they really sort of fully appreciate the evidence behind their care? We try to, yes. So lots of yeses, which is great. Okay, thanks for that. And then if we could go on to the second question. Do you use NICE guidance in your practice for wound care? So there's lots of yeses, which is reassuring. No, okay. So we'll just have a few more seconds looking at those answers. But predominantly that looks like it's yes. So that's great, thanks for that. We're going to finish the session today with a couple of questions as well, so keep your phones handy. So I'm delighted now to introduce our first speaker. It's Dr. Leanne Atkin, who's a vascular nurse consultant from Mid Yorkshire NHS Trust and also a research fellow from the University of Huddersfield. So, Leanne, I'd like to come to the stand. Thank you very much.
I'm like my mother. Oh, I was going to pick up that. It weren't my tissue, but I'd have still picked it up. Good morning, everybody. Thank you so much for being here very early in the morning, and thank you to Ergo for sponsoring this symposium. My name's Leanne Atkin. I'm a vascular nurse consultant from Mid York's NHS Trust, which is in Yorkshire, hence the twang, and a researcher at the University of Huddersfield, and they speak even weirder than I do. So my session today really is thinking about how do we use that clinical evidence to support decision making in clinical practice. I thought those two questions that Sarah asked were really interesting. Okay, do you have an evidence-based pathway? Yes, we do. Do we have a standardised approach? No, we don't. And I think that clubbing those two things together were a bit misconstrued, because in a way, I bet you all have evidence-based pathways, but I bet your implementation of those across your districts is absolutely hit and miss. And that's the bit really that we need to focus on. How do we simplify this so therefore we do get that standardised care going forward? So really, I just wanted us just to reflect, evidence-based practice, I can remember writing about it in my nurse training. Can you remember the Sackett et al. Reference that we all used? I'm taking you back, Anne, and I'm taking you back. It was rather a new thing. I trained in 1993. It was still relatively new, or the thought about using evidence-based practice at that time. And I just thought it'd be useful for us just to reflect on those definitions. So when we talk about evidence-based practice, it's about using that conscientious, explicit and judicious current evidence to make those decisions for the individual patient care. But it's actually bringing together those decisions which are based on that available current and relevant evidence, along with being informed by that professional and also allowing that patient to make their own individualised choice. So when we talk about evidence-based practice, really, it means that clinical decision that we're making. But it's that clinical decision that's based on the best available evidence, your clinical expertise, along with that patient's preference. And they're the three things that we need to sort of throw into this pot to make sure we get good, high-quality, evidence-based care at the end of it. Sarah sort of touched on this. Why is it so important? Well, it's so important because of the current variations in practice that we've got across the whole of the UK that drive me insane. Those variations really impact the quality of care that your patients received. They result in higher cost, a bigger burden to the NHS. And actually, there's a huge potential by that non-standardised practice for harm, patient errors, and a patient safety issue. So by standardising practice, we can impact on patient safety, patient experience, and the effectiveness of the care. And just to bring that home to you, this is what I mean by ensuring we've got evidence-based care. We know how to manage a patient with a venous leg ulcer. We know from level 1 evidence of what we should be doing. But this is the reality, 37% healing at 12 months. Well, actually, if you get standardised practice, you can get healing at 86% at 6 months. And we know this through standard arms, the control arm of randomised control studies, that you can get healing that good. In fact, you can get healing even better. In my organisation, we're healing 72% of all patients with venous leg ulceration within 12 months, no matter which front door. And it's really important when you think about the front door. When I use that terminology, the front door, it's a new NHS expression that's coming through. But it basically means whichever door that patient accesses, primary care, practice nurse, community nursing, urgent response services, walk-in centres, you get the same standardised care. And that's what we've managed to do within Mid York. So it is possible. And why do we need to do this? Well, you guys could write numerous papers yourself on the burden towards wounds in the NHS. But let's just remember, an unhealed venous leg ulcer costs 4 times more than managing a wound that's healing, 4 times more. That equates to spending even £3,000 on a patient that's healing versus £13,500 on a patient that's non-healing. Well, that's massive. And actually, when you look at the spend within the first 12 months is £1.3 billion. Well, actually, therefore, we could save easy £6 billion each and every year if we just managed to get those patients to heal within the first 12 months. And that has to be our goal. So just for a second, I want you to think about this patient that we're talking about. I just want you to think about, what does that person look like with a venous leg ulcer in your mind's eye? Who do you picture in front of you? Would you go and see patient X in room so-and-so with a venous leg ulcer? Who do you think you're going to see? I think I'm going to see this. I think it's a lady. I think it's overweight. I think she's a grandma looker with a bit of grey hair and a bit of glasses on, and I think that's my standard venous leg ulcer patient. But it's not, is it? Because this is Tracy, and she had a venous leg ulcer. Tracy is not that picture. She's a very different lady. And this was her venous leg ulcer for all of that years of time because of inadequacies in terms of standardised practice. I just want you to think about, what's the impact of that non-healing? Forget the money, forget the nurse's time, but what's the impact of Tracy, that young girl, that woman, that mother, that wife, that individual? How would you feel about living with a wound like that on your leg for all of those years? And that's the reason why we need to change. That's the reason why we need to standardise our practice, because it's simply inadequate, the care that we are providing the majority of our patients. But we have a huge challenge coming our way, and it sort of frightens me. If you look at the statistics of the ageing population, the numbers are increasing. Look at the numbers, those that's still at work. They're getting less. So we are moving at this moment in time, it's probably about 60% of patients, people across the UK in work, supporting 40% of non-workers / retired. When you start to look at that, the figures are going to shift. 70% of our population are not going to be of working age. How on earth does our tax support that? And then on top of that, there is an exponential obesity crisis. Look at the numbers, look at the curve of that graph. That's just from 1975 to 2015. And look at the tsunami that's coming. 72% of patients 16 to 24 are obese. Well, they're going to filter down this timeline. If you're obese at that age, you're going to be obese probably for the rest of your life. What is our service going to look like when they reach 40, 50, 60, 70, 80, 90? And I stand in front of you as an obese woman. I know I should do something about my weight. Every morning I think I will. And by 4 o'clock every morning, every afternoon, I'm probably eating something I shouldn't. How do we change this mindset in these individuals if I can't even change my habits and my lifestyle? But along with obesity comes two huge factors when we're talking about patient health. We know that obesity is more prevalent in deprived and in patients in disability. These are the sitting ducks, if you like, for venous disease. These are the patients that are going to have functional venous disease, calf muscle pump failure, huge amounts of dependency. They are the ones that's going to be very, very difficult for us to manage in the future. So we have to get our care right. If the tsunami is coming, we've got to standardise our care. We have to do it right first time. We have to prevent as much burden as possible. So when I want you to think about evidence-based practice, there's 3 things that you need to think about. Number 1 is there sufficient evidence that's been published in that specific field? The next thing is, what's your skill? Do you have the skill in how to access that literature? Do you know how to critically appraise a piece of research? If not, there's great courses at University of Huddersfield. Plug. And then actually, do you have the power to implement that change? If not, how can you access that change? So that's what we need to be thinking about when we think about evidence-based practice. Some of that actually is difficult. How do you influence that change? How do we get that wider organisation change? How do I ensure that I'm good at reading that piece of research so the outcomes are true and meaningful, they're valid, they're reliable, they can be generalised to my patient population? I use all those words and some of you might be thinking, nope, can't do any of that. Well, that's what NICE is there for. NICE are a body of experts at literature and publication expert review. And I just want you to remember what NICE is. It's an independent organisation, completely and utterly independent. And their responsibility is to produce national guidance to advise and improve health and social care. NICE is non-governmental, but funded by the Departmental Health. It is completely independent. Nobody has an arm in there or an impact in there that's not allowed. They have an appointed chair, they have a board, and they have huge regulation that sits behind them. And the role of NICE is to, as we've been talking about, it's about helping us to reduce that variation in clinical practice by actually assessing that evidence base that's out there. It helps us to resolve that uncertainty. Is that beneficial for my patient, yes or no? NICE helps us to do that. But it also balances it with, is it value for money for the NHS? So it really helps us to set those national standards of how patients should be treated. And if you've not been involved in NICE, I urge you to. Just go and sit on NICE. As you can go as a public member, you can just go and sit in the sideline in any of the NICE committees. There's some down in London, there's some down in Manchester. Just go and sit, because once you've sat in that meeting, you understand the rigour that's involved in this process. They are extremely scientific. They are inclusive of every single piece of published evidence that's ever been done. They do better systematic reviews than I've done in my whole research career. It is completely transparent with independency. There is an opportunity for outsiders to challenge their results. There's a further review, a complete implementation plan. So absolute clear and transparent inclusivity of the evidence that they're able to review. And from that, actually, they want us to consider, really, what are their recommendations? And they'll think of two things. What is the clinical evidence? And what actually is the economic evidence? Should we be using it? Is it clinically beneficial? And is it value for money for the NHS? And NICE, really, in terms of their technology guidance, can be quite harsh. You know, many of their technology guidance come out with a very negative stance. Should not be used. Should only be used in research. Optimised and recommended. And I can tell you I am the clinical lead for the whole of the Vascular team now, and I can tell you if NICE tells us to use a medicine, we have 28 days to get that medicine on our shelf to use. If NICE tells us not to use a medicine, we've got 28 days to remove that medicine from our formulary. If NICE tells us we should be managing patients in this way, we have to get an implementation plan. If we don't, we actually have to put a letter back to the clinical board of why are we not NICE compliant. That's how powerful NICE can be. So in 2019, NICE first published their recommendations relating to the Ergostart treatment range. And actually it's just been reviewed in last month, in fact. And actually their recommendations are really strong. Their recommendations is Ergostart is recommended as a cost-saving options in the treatment of patients with, they missed that bit out, diabetic foot ulcers and venous leg ulcers. And actually they've made a very clear recommendation to say there's not enough evidence to support its routine use in patients without a venous leg ulcer or a diabetic foot ulcer. So the recommendations are clear. So I just want you to really question did your patients have access to this? If not, why not? Because the evolutions of dressings have come on tremendously. I can remember the proflavin gauze being packed into wounds when I was on a staff nurse. We've gone through that passive goodness knows what stage, onto this environmental stage where we talked about that moist wound healing, removing the barriers in terms of that environmental change. But actually, if you think about it, that's where all the dressings that you're probably using have been invented. They're all from the 1980s, 1990s. A foam dressing is not an advanced dressing anymore. It's something that was made in the 1980s. We really need to be thinking about how do our patients get access to this next wave of dressings, the wave of dressings that's actually having an interactive element, either to the growth factors, to the cytokines, to the MMPs, to the wound bed, changing the dynamic of the wound itself, not simply the environment. So that's how we need to be focused on. If any of you's done any form of academic study, you'll be well known to this pyramid of evidence. But you've got to think about what actually are you wanting to make the change. Because actually what I want to look at is randomised control studies, especially double-blinded randomised control studies, because they really tell you, is this making the impact or not? The reason why NICE was able to make such clear recommendations is the evidence that's been produced on the Ergostart treatment range. They did an Explorer study, which was a multi-centre randomised control study with 240 patients looking at the healing of diabetic foot ulceration. And they were able to say at the conclusion of this that you get increased wound closure by using the Ergostart treatment range. This was actually, at the same time, sort of parallel study was the Challenger study that actually looked at, again, a double-blinded randomised control study looking at 187 patients with venous leg ulceration. And they were able to say that actually by using the Ergostart treatment range, you have an increased reduction of wound area in the first 8 weeks. We all know how important that initial response is, that window of opportunity of healing a patient with a venous leg ulcer. So it's not surprising, really, that the NICE says very clear recommendations. They state that evidence supports the case for adopting Ergostart in the use of patients with diabetic foot and venous leg ulcers. And this is because it's associated with increased healing compared to non-interactive dressings. They also go on to say that there's high level of evidence. They go on to say that you can get improved healing rates and reduced cost, and you can save significant costs, especially when you start to times it up by the overall population. So, you know, when you're considering what you're having on your formularies, what dressings you want to recommend to your staff, is it a bit all of these? Now, have you ever actually sat in front of that rep and gone, oh, it's only a case study, I want a randomised control study? And then tomorrow the next rep comes and goes, it's a randomised control study. Yes, but it's not to do with my patient population, is it? So I'm not really bothered about that one either. And actually, sometimes does it feel like this? I want that one. I want that one. I want that one. And we seem to change his mind for these lovely company reps of being a bit of a swine because actually we don't know which is the best. But actually, that's where the role of NICE comes. I seem to have lost a slide. That's where the role of NICE comes. That comes in terms of they have made that choice for us. They've looked at the widest part of evidence. Surely none of you think you are better than NICE in terms of looking at the inclusivity and the validity of that evidence. I certainly don't think I am, and therefore I'm happy to accept NICE recommendations. I think I've simply got one question for you. Would you say you're an evidence-based practitioner? The answer can't be sometimes. You either are or you aren't. And there is no sometimes. So you really need to think about reflecting on your own practice, your own formularies of how can you be an evidence-based practitioner and how can you enable the wider of people within your service to be an evidence-based practitioner. Because why would you choose a non-proven approach? Anybody fancy this to help you with slimming? There's a lot, you know, Adele's all over these days, isn't she? And Lorraine Kelly is another one. Kim Kardashian, she's always selling some green pills on my TikTok feed. But you know, actually, it's just diet and exercise that works. Would you fancy these blood pressure supports from Dr. McCono or whoever? Do you fancy buying these if you've got hypertension? Or would you prefer something like a Ramapril? It's a simple, this is evidence-based practice. But I'm really keen, if any of you know me, I don't like to make things complex. I like to simplify things wherever possible. But please, please don't think simple is actually rubbish. Simple is just having this clear cause and effect that's been identified. We know what we're doing. I think within wound care we need to reduce the complexity and we need to uncomplicate this. And to help this, I'm sure many of you know about the Atkin and Tickle pathway. We are a bit of pathway queens. You'll know that this is our algorithm that we produced some time ago, and we did this as a response of Venus 4 for the use of compression hosiery kits in the management of patients with venous leg ulceration. And I'm quite happy that we've updated our pathway to actually look, and actually we've made that NICE recommendation that any patient with a venous leg ulcer should have Ergostart treatment range at the point that they start their compression. Because why not? NICE is telling me that they're more likely to heal, I'm more likely to reduce costs, I can standardise care, why not? So all I'm asking you to really think about is how do you standardise your practice? And I think it needs to be standardisation through simplification. Because by doing that, you will reduce the variation in your care. You will start to focus on healing. You will enable the change, the wide system change that we need across all of the communities that deal with patients with wounds. We should be here to provide barriers, not solutions. Don't be that nurse to go, do you know what, I might not, I might need this type of evidence. Don't be that nurse. Let's accept the evidence, let's accept the nice recommendations, let's start to make the change. Let's embrace this. And I urge you all, please think about how do we make sure that we're healing patients within a matter of days/weeks, not weeks/months. It's time to standardise your practice until it becomes the norm. Thank you very much.
If it's okay with you, we'll take questions at the end for both of our speakers. So now I'm delighted to introduce Joy Tickle, who's a tissue viability consultant nurse from the Isle of Wight, who's going to be talking to you about sort of real life experiences, clinical experiences that have had positive outcomes when evidence-based practice is used. Thanks, Joy.
Good morning, everybody. Thanks, Sarah. I hate following Leanne. We have this standing joke. I always seem to follow her. I'm the one that follows her behind. Yeah, so good morning, everybody, and welcome to the symposium sponsored by Ergo. How to make the right dressing choice? Wouldn't it be easy if we just said, right, on every wound you use that, and on this you use that, and on a DF you use that? But we can get it right. We can get it right with what Leanne has talked about already, about that consistent, standardised, evidence-based approach. But when I started to look, particularly in my workplace, I'm a big believer, and I'm not as academic as Leanne. I'm sort of very much on the ground with my kneeling pad now because I'm of a certain age, but we should all use our kneeling pads. And I like to get in there, and Leanne does as well, but I do probably a little bit more of that with various different wounds as well. So I was looking at gold standard treatment. You know, what do we mean by gold standard treatment? We use that word all the time. Okay, we see it in literature, we use it in practice. So what do we mean by gold standard treatment? So I Googled it, I looked at it, I asked my colleagues. I sat with my colleagues 2 weeks ago and said, what does gold standard treatment mean to you? And you can see on the screen, we've got various points. Oh, it's the ideal, it's perfection, it's what we should deliver, it's what is expected, it's best evidence. And yet it is all of those things. And again, as Leanne has, I will challenge, do we really understand gold standard treatment in wound care? Do we always deliver it? Or do we choose to or not to? What makes us reach that decision? And then it made me think about our patients. What does gold standard treatment mean to them? I think every day, you know, we go along to our patients or in clinic and we say, oh, we're going to give you the best treatment, or we're going to use this treatment. Or do we? Do we actually explain what treatment we are delivering? And I don't mean that in a negative way. We've just launched our formaries and clinical pathways on the Isle of Wight, and one of our patient stories was on about she didn't understand what the treatment involved. So if the patient doesn't understand, do we understand, or are we just choosing not to explain to them? So these were some of our patients' comments. I asked them, I was in clinic and I said, look, if I was telling you we were going to give you the gold standard treatment for your wound, whether it be a pressure ulcer, a DFU, a surgical wound, a leg ulcer, what would it mean to you? And these were their comments. These were not my comments. I want it to help the pain. I want it to let me leave the house, i.e. the gold standard treatment for all my wound will mean that I can leave the home. It will reduce my pain. It's what I deserve. Don't I deserve the best? And that's true. And very much around their gold standard treatment, where we would say, oh, it's to heal the wound because we're clinicians, actually, a lot of their comments were around their symptom management, improving their quality of life. Yes, they wanted their wound to heal, but the first things they wanted were these points. That was gold standard treatment to them. So we need to combine the both, don't we? We need to make sure we're embracing the patient's gold standard as well as the clinicians and treatment's gold standard. I'm not going to go through all of evidence-based treatment because, you know, Leanne articulated it extremely well. These are all the comments. If you Google, if you look in evidence, if you look in literature, if you look in research, this is what evidence-based practice should look like, what it delivers, and what are the advantages. For me, the key points, some of the key points I picked out was this one: to focus on nursing practice away from habits and tradition and use evidence and research. And the advantage of that is we're, of course, providing better patient outcomes, but we're making decisions based on knowledge that is backed by research. And we do that. I'm not standing here in this audience and criticising anybody. We have to be experts in so many different fields. We have to ensure we have that evidence. But if you're anything like me, Leanne's fantastic at looking at research and can unpick it. I don't necessarily have that skill as well as Leanne does. But I would expect when I'm delivering, let's say, wound care, that my organisation or my nurse specialists or my vascular nurse specialists have unpicked that evidence for me, have read that research, looked at NICE guidance and embedded it already into the clinical pathways or treatment recommendations that you're being asked to offer your patients. And if not, it's your position as well after today to challenge your organisation and challenge your clinical leads for wound care. Why are we not embedding NICE recommendations or research or evidence? Why do we have the right to choose or not choose? And Leanne's right on that. And one of the issues I will say to you, we all know about the National Wound Care Strategy, about reducing inequalities and multiple variations of treatments. We know about the work with Legs Matter and the national campaigns about gold standard treatment, best evidence for leg ulceration. It's been embedded in us as full therapeutic compression. But why even now in 2023, and Leanne will agree with me, that we choose whether we embed that evidence, i.e. your patient down the road, venous leg ulcer, not in compression, but you're delivering care. Patient further down the road, different team, venous leg ulcer, full compression, you've embedded the evidence. Why is there still that inequity? Why do we have the right, which we don't, to choose whether or not that patient receives that evidence? Because all we're doing is really potentially causing further harm. And I get why we don't, because some of us aren't the decision makers to embed that evidence. But as clinicians, wherever you work, we are accountable for challenging that lack of evidence. And I know every day when I work, I was on the island on Monday. I didn't swim across, by the way. It was a lengthy journey. We got the ferry, but we got here. A day doesn't go by when I don't get asked, what dressing? What dressing shall I put on this? What dressing shall I put on a DFU, diabetic foot ulcers, the pressure ulcer? And I can see some of you nodding in the audience, and I appreciate your honesty, because we do focus very much on the dressing, but the dressing is there to help us to assist wound healing. But so is the holistic assessment, so is the thorough assessment of the vascular supply. But there is still confusion. And I get it. There's a plethora of different treatments out there, different dressings. Let's just be specific to wound dressings, okay? And that's going to cause you confusion. It's going to cause difficulties in making decisions. And then that leads to ineffective treatments, so longer wounds taking longer to heal. We frequently, unfortunately, do then base our decisions on simplicity. Oh, right, okay, well, I'll use that because I'm familiar with it. It's simple and, you know, it's easy. But is that right for the patient? But I understand why sometimes that choice is made. And then we don't know what the best dressing is, so we frequently overuse different dressings, ineffective dressings, or dressings because we keep frequently swapping them, don't have chance to be effective. Because on average, you know, as Julian Guest said, on average, our patients will have 8 different prescriptions of wound dressings. You know, 8 different treatments because we are confused, or we don't know how that dressing works. And I'd love to be able to have a lot longer, Sarah, which I won't, I promise I'll finish on time, to just ask you all, you know, put a dressing up on there and say, do you know the mode of action of this dressing? And I would hope that 100% would go, yeah, I know how that works, if it's used in your care area, environment, and I know what it does. But again, it is that confusion because the amount of dressings. But what I'm saying is there are standardised treatment pathways already available. There's clinical evidence already available. We don't have to reinvent the wheel. It's already there. We've heard off Leanne about the hierarchy of needs of research, and I'm not going to go through all of that because it's far too technical for me. But what about the hierarchy of needs for the patients? We can adopt, you know, Maslow's hierarchy. Do you remember that as well? Maslow's hierarchy of needs. But just using something as simple as that, we can adopt that model and we can have a similar hierarchy of needs, but our patient's needs, our patient's wounds, the patient's wounds needs. And we can embed that, and it can help you to make decisions about the right treatment or the right dressing. So you can see we can have literally guide you through the simple needs of easy to apply, atraumatic, allows that moisture balance, through to more advanced needs where we want the balance of the MMPs, to debridement, which altogether meeting the basic and the advanced needs means we deliver gold standard care. We deliver and allow the wounds to heal more quickly, and isn't that what it's about in embracing? So joining up the evidence alongside the hierarchy of the patient's needs, the wounds needs, we can and have delivered that gold standard. Leanne's already talked about how that could be met. And I'll just want to now begin by sharing my experience. I'm very much clinician through and through. I'm on the ground. I believe, you know, that my patients teach me so much. They're not mine. They don't belong. I don't take them home with me at the end of the day, although some of us probably do in our head, don't we? But I get very passionate about patients' quality of life. I really do. Can get quite upset around patients' quality of life when I see it. So in my previous organisation, a few years ago now, I did look at the evidence. I look at NICE. That's part of my role. I'm a clinical lead. I'm a tissue viability nurse specialist, or I'm a TVN, or I am a wound care nurse, or I'm a practice nurse delivering wound care. But for me as a lead, it's my responsibility for all of you, or if you work with me or within our organisation, that I look at that evidence, that I look at NICE recommendations, and we do. And Leanne's right, every organisation will have a link to say when new NICE guidance has been produced, and we have to respond whether we implement that or not, with the rationale. So that's part of my role. So when I looked at the evidence, the research, and NICE recommendations around the Ergo Start, it was like, well, why wouldn't I? You know, it's there. I'm going to have a look at it. I'm going to look at a simple pathway that we can implement it into practice. And, you know, why wouldn't we do that? So that's what we did. And what we basically, I say basically, we implemented, how did we implement the evidence? How did we get that research and that evidence into practical terms? It's just a really good, standardised, simple treatment pathway. And that's all, I say all we did, but it was simple. It was simple. And we obviously looked at clinical outcomes of the results of that treatment, but most importantly, for me, we recorded all the patient quality of life outcomes. What did it actually mean for the patient as well? Not just how many weeks we healed the wound in, which we did. We had fantastic results on very complex, challenging wounds, but on very simple, smaller wounds as well, but very timely. And it was that standardised approach that we looked at. So why wouldn't I then, when I moved to the Isle of Wight in 2020, why wouldn't I take that with me? Why don't I transfer that evidence? Why would I choose not to transfer it into the organisation I'm working with? Because it wasn't embedded there, and I'll be honest, but it wasn't difficult because I've got the success of before. It wasn't my success, it was the clinician's success. It was the patient's success, okay, of the treatments. So why wouldn't I move and take that with me? Why would I not embed something already proven? So what I would like to do is share with you some of that evidence into real life, and I like real life, with real life patient stories. I've got lots of stories from when we first implemented the pathway in my previous organisation, and I've got these really effective patient stories now. And I think we all like pictures, don't we? I do. I can relate very much. I like a story. I like the patient to tell me their story. And we recorded recently a patient story. And I know, Leanne, you've done a video, haven't you, of your patients. And just hearing a patient talk about their wound, about their life, and about the impact, as Leanne talked about on her younger patient, it just speaks volumes to me. And I think case studies, I know everybody says, oh, a case study, but isn't this what it's about? This is about the person. So too often in practice, I'm going to be honest, we can relate to that patient on the screen, can't we? We can relate to the fact that this lady's got a chronic non-healing wound. She's had that wound for 4 years. So Leanne's talking about months. I'm still seeing patients with not just chronic venous leg ulcers, with some pressure ulcers. We're talking years, certainly multiple months. I can't imagine living with a wound for a month. I'd be so miserable. I would just be unbearable. And would you think that would be acceptable for your mum or you? And we talk age, don't we? And Leanne's right, but that could be somebody in their 50s who's trying to work, trying to be independent and be a mum. But this lady, she had got multiple comorbidities. And let's remember, guys, we're not just dealing with wounds, we're dealing with those multiple comorbidities, all the factors that might delay the wound healing. The patient had rheumatoid arthritis, she had difficulty with mobility, she was in pain already because of her comorbidities, but equally due to her wound. She was retired, but she was a grandmother. She was a wife. She was independent. And you might say, how can she be independent? She didn't walk much. She's got rheumatoid arthritis. And believe you me, that was a comment made to me by a clinician. Of course she can be independent. We can all be independent. She loved being a grandmother. She loved having her grandchildren over. Okay? This stopped her because she got embarrassed. She didn't like the smell, so she stopped the grandchildren coming. You know, the grandchildren often made comments about, what is that smell? Why have you got a bandage on your leg? Why is it leaking? She had 4 years of this. She had multiple various treatments over those 4 years. So when clinicians met her and said, we're going to heal this wound, Leanne, she didn't believe them. Why would she? So when we commenced the pathway, the ErgoStart pathway and the referral pathway, we spoke to her and we were telling her about evidence and research and not in detail, but we just said, you know, we have this, it's been, you know, very strong evidence. We'd like to use it. She just dismissed it. It's not going to heal and all the other factors. Pain score was high, quality of life score was very big impact psychologically on her quality of life. Multiple treatments. Now, the heal by week 4 is wrong, so I'm going to put my hand up there because I bet you think, God, Joy's God. She's a miracle worker. It was actually, it's 20 weeks. But 20 weeks compared to 4 years, I still know what I would prefer. And on the very last picture, it's not completely healed, you know, but at 20 weeks it was. But what I'm trying to say here is the impact, and all we didn't change anything else in her treatment other than applying the evidence-based treatment, the ErgoStart, from day 1. So we didn't think about it. We said, no, she's got a venous leg ulcer. It was mixed, but she had got venous disease as well. The evidence suggests from day 1 we should be doing that, and that's exactly what we did. The quality, I mean, it goes without saying, you don't need me to reiterate to you how her pain score improved, quality of life improved. She could have it wasn't leaking, she wasn't embarrassed. This lady hadn't shared a bed with her husband for 3 years. Okay, now I will say to you, some of you might go, that might not be a bad thing. Actually, some of you may say, I already go in the other room because of his snoring or her snoring or your partner or whoever. What I'm saying is, you know, it's massive. It's a bigger picture because it's not just affecting her life, it's affecting her husband's, it's affecting their relationship. But wow, the fact that she was over the moon when she told me she'd actually shared a bed with her husband. I did say I don't want the details, but to me, biggest smile ever. And it wasn't my care. It wasn't my treatment. It was the pathway, the standardised approach, because I didn't dress a wound all the time. The practice nurse did. Okay, so it's about being transferable. Our second patient, see, I keep choosing these older patients, but sometimes these older patients can be a little bit more complex with their polypharmacy and their comorbidities. Now, this gentleman lived in a residential care home. He's 93, and I'm sorry, but I still hear comments made, well, it's okay, he's 93, doesn't matter. My mum's in hospital, and everybody asks her age. Don't ask her her age. Everybody deserves the care, irrelevant of their age. He's 93, he lives in a care home, but he is independent. He likes to live there. He has a really good social life in the care home. They go out on trips. But guess what? This man is diabetic. He understands diabetes better than I do. He developed a diabetic foot ulceration to his toe. And it was painful. He hadn't got total neuropathy. But his biggest concern to him was he was going to lose his toe or his foot or his leg because he knew the risk of diabetes. So his anxiety levels and fear were through the roof. Okay. Now, he'd only had it for 4 weeks, but in those 4 weeks, he'd had 5 different dressings, treatments applied, with no real clinical rationale of why, because of the variations. So we implemented as you know what I'm going to say, we implemented the pathway, the ergo start, nothing else changed. The debridement stayed the same. This gentleman was having to attend podiatry appointments because they don't do domiciliary diabetic foot ulceration appointments, but didn't want to. It was inconvenient, which I know, but the care home as well had to take him. So, that was beginning to get him down. But with the simplicity of the treatment that could meet his basic needs, wound management, desloughing, and his advanced needs of getting the wound to heal, with the district nursing team, he actually didn't go up to, he went to podiatry once, but with the shared care with podiatry, that was 4 weeks. And we're not talking 4 months. And the impact to him was massive. He wasn't sleeping because of anxiety, but he wasn't sleeping because of the bed clothes. And I'll put everything back to basics, guys. This isn't about us just talking about gold standard treatment. We're talking about the things that matter to your patients. And I always say to every nurse I meet after 40 years in nursing, just when you first look at your patient or speak to them, imagine that's your mum or your brother or your sister or your partner. Then will you, maybe change the way that you think? Hopefully not, because you are thinking like that. Do they not deserve the gold standard? And the final patient is a 72-year-old lady. Sorry, Sarah, I'm nearly finished. Multiple comorbidities again. She'd had a CVA. To you might think that wound doesn't look much. What I'm trying to show you here, it's not the size of the wound, guys. It's not the depth of the wound. A wound is a wound, okay? Doesn't matter if they've only had it a day, they've only had it a week. I know we're talking about long durations here, but gold standard evidence-based treatments should be day 1. Don't wait a week. I still hear this, when I go out with some clinicians, and I have heard in the past where they'll say, okay, they've only just developed this wound, or we've only just assessed them this week, so we'll put a simple dressing on, and then we'll wait about 4 weeks and evaluate, and if he doesn't respond, we'll put something a little bit more advanced on. No! Why are you waiting 4 weeks? Start at day 1. Like we said, evidence and gold standard doesn't just start at week 4 or week 20. It has to start at day 1. And again, this patient, 6 weeks non-healing, very independent lady, dependent on her husband now to take her to clinic appointments and everything else. The wound bed had some granulation, exudate was moderate, peri-wound skin irritable and dry. Her biggest irritability, said that without a drink, was her husband. Sorry, but it was. Because she had this wound, she was dependent on him to take it, not just for practice nurse appointments, everything. She couldn't get on the bus and do her own shopping, she relied on him. And that caused, daft as it seems, massive fallout problems for them. And the wound was not healing. So she was getting so frustrated, 6 weeks, and we talk about the cost to the patient, but equally, what's the cost to the patient? A lot of our patients, we talk about healthy lifestyle choices and transportation and things like that. Can they afford it? No. So going up to the practice twice a week, we have some patients who go in a taxi. Can they actually afford that? So it's not just about the clinical outputs, clinical positive outcomes. It's also the patient ones. And again, week 4, this completely healed, and we did nothing any different than implemented that standardised approach. We got the evidence, we got the recommendations, we translated it, all that research, we translated it into a practical means. But it's already done for you, okay? It's already out there. The standardised clinical pathways are out there. And, for this lady, she, you know, of course, reduced anxiety, reduced stress. That goes without saying. And the fact then that she could actually have a better relationship with her husband because she didn't want to kill him or, you know, barely kick him to the curb. So on conclusion, what I want to say is we really must, as Leanne said, embrace treatments, but treatments that have got strong evidence, right, that are not comfortable or familiar, you know, or traditional without evidence, okay? We have to stop doing that, and this has to be, and I love Leanne's approach, it has to be the norm. But it won't become the norm till you do it, okay, until you do it regularly. You saw in the case studies, most of the patients had unsuccessful treatments for a long period of time or multiple variations. Why are we doing that? You know, we've just shown we have treatments, simple treatments that meet the basic needs to the advanced needs of wound healing that allow those wounds to heal more quickly and with positive outcomes. It's already done there for you. There's clinicians and specialists in this room. There have produced pathways. We've got the ErgoStart pathway. We've embedded it into our formulary. It's embedded into our clinical pathways. And that's so I can also reassure our organisation confidently we are using evidence-based practice. And I think you can already see there, and Leanne very well articulated the evidence around that. And, you know, why would we choose not to implement evidence from day one? Why are we waiting to heal our patients? Thank you very much.
Thanks, Joy. Thanks very much to our brilliant speakers. So we've got now some minutes to take questions. Has anybody got any questions to either Joy or Leanne? We've got our roving mics somewhere. Anybody? Go on, I know you've got a question. Yeah, absolutely. Yeah. Yeah, question here.
Just while I was listening to you, it was brilliant, thank you, really loved that. But I still know quite a few tissue viability nurses in my area that still won't even allow class 1 compression. So how do you encourage other practitioners to follow guidance, especially when they're her patients, and I obviously want the best for her patients too, but how do you encourage that?
Changing the mindset of people that I would class as outdated dinosaurs is really difficult. It's really difficult. But what I would say is we need to constantly chip away. We cannot accept that. You cannot say, so therefore I can't do anything different. You've got to keep bending the ear of the evidence base and the time to change. Most people eventually you will start to turn their mindset, but it's about really understanding what are their beliefs and why do they think they're better. Why would any individual think that they're better than the National Wound Care Strategy recommendations are of NICE? I just don't get it. But I see this in society. Now I'm on his soapbox. We've all got bosses. So to me, I'm not understanding why they won't do what the boss is telling them to do in terms of National Wound Care Strategy and NICE. But you see this, don't you, all over in terms of especially, you know, the most junior nurses on the wards, if you see them. Why should I do that? Well, because your boss has told you to. But why? Don't care, your boss has told you to. You won't find that type of outside behaviour in a factory. Do you know what I mean? You'd conform. This is what you should be doing, therefore we should be doing it. I don't understand, in a way, how we've empowered people so much that they've gone rogue. But I think for you as an individual, you've got to be careful. These are your patients when you're treating them. There might be her patients on her caseload, but when they're in your care, you're treating them. So therefore, you'd have to justify if one of your patients complained and I were on their expert panel, you'd have to really question, why didn't you do that? Why didn't you follow those guidelines? Why didn't you implement that 20 milligrams of mercury pressure? And it would be you that have to justify it. You wouldn't be able to simply say, she told me I couldn't. So, you know, it's really difficult, it's changing mindset, but it's about pick at them. Yeah. Think of him as your husband, and you do want that holiday that he says we can't afford. Think of how you get that holiday in the end. Or wife, if many husbands, but men aren't good at that, I'm sorry, they're not. You know, you plant that seed, you grow on it, you make your change. It's a long-term plan. Don't get disheartened if after a week or two you haven't changed your mindset. Think of the long-term strategy of how you're going to get what you know you need to do for your patients.
And I think you're right from a point of view. I was challenged from the medicines management team because, again, why do you want that dressing? Why do you want Ergo-Start on? It's expensive. No, it's not expensive if you show them the picture. It isn't, because you're meeting all the needs, you're healing the wounds more quickly, you're improving the patient's quality of life. So basically when they're on the painkillers and the anti-anxiety pills because of their wound, it's improving loads of things and reducing costs. It's reducing your costs because you don't have to visit as often. But they challenged me, we're not having it on. Why are you not having it on? Well, it's too expensive. So what I had to do is, yeah, you chip away, but you chip away. How I approached it then was with the evidence. Well, there you go then. If anything goes wrong in this organisation for our patients with a wound, and you wouldn't, allow us to do that, NICE are recommending it. And it was actually the NICE bit, not all the RCTs I was showing them, it was the NICE bit that they went, oh, okay then, we'll implement it. And then what I had great pleasure doing is later on, I just went into their meeting without them even really asking me to, and I showed them some patient outcomes. To me, that spoke volumes. They were like, oh, those are patients. Yeah, so chip, because it can come from different levels. It can come from on the ground or it can come from above.
Joy, can I just ask you, when you were going through that process, did you have to present any data to them in terms of sort of healing rates that you've currently, or poor healing rates, which gave them that case as well?
Really good point, Sarah. Yes, I mean, evidence is evidence, but local evidence is even better. So we had a database, very crude, I'm going to be honest, because you're all going to say, can we have your amazing database that collates all of this? It was hard work, but have facts. So we had the healing length of times for patients or not, as the case may be, the cohort of patients we're looking at, and then after we implemented the pathway, is the results after for inclusion. So we had our local data, but what I will say is I did use a lot of just the research, the Challenger study, Explorer and NICE, but I will still say they got that data and they understood that, but my biggest power, if I'm honest, I'm not a power crazy, honestly, was the NICE. Because
to get onto our formula, it was so easy. Our medicine optimisation group normally give me hell in terms of why do you want that foam over that foam or that silicone over that silicone. I walked in with one paper, the NICE recommendations. Within 20 minutes, the discussion went over it. We're on the formula. That's the power of NICE.
And that's what
the medicine optimisation group understand the role of NICE better than actually the wound care fraternity.
Yeah, they do.
But I think that demonstrates also the importance of leadership in terms of our speciality. I've faced these area prescribing committees where I'm trying to get products onto formula. It is like going into Dragon's Den. And it's about really knowing your stuff, isn't it? And it's frustrating when they don't listen to you. You know that more than they do. You've done your homework. But sometimes it is frustrating that you're in front of a panel of people who, aren't interested in wound care and basically just see it as a number crunching exercise. So I think, it's about leadership as well, isn't it? And having a good case to take forward. Yeah. I'm aware we're at time. We did have a last Slido question, really just summarising, about, having attended this session, do you have a strong belief that it is beneficial to your patients to implement NICE guidance? I don't know if you just want to quickly do that, please. We'll just do that one question. And I hope on the back of this session this morning, the answer from all of you would be yes, it is beneficial. So let's have a quick look. Can't see any no, so that's encouraging. Yeah. Okay, 100% yes. That is brilliant. Thank you so much for attending. Thanks again to Ergo for sponsoring, and particularly thanks to our amazing two speakers for their sessions this morning. Thank you.